One of the important things of choosing a team that is specialized in this care is to mitigate the risks. And two of the risks that are mostly feared by patients and I guess doctors alike are firstly fat embolism syndrome and secondly DVT or pulmonary thromboembolism syndrome. And you can see these words are so big that even I struggle to pronounce them. But essentially these two complications are the ones that scare us the most. And they scare us because they can be very serious, and they scare us because they can be quite unpredictable. Because a lot of times they occur because of a genetic predisposition. So we can do mitigation strategies, we can try and reduce the risk as best as we can, but ultimately the patient's genetics plays a role in terms of predicting whether they can have these complications or not. Now the first one, fat embolism syndrome, is where fat droplets from the marrow cavity of the bone circulates through the bloodstream and goes and sits in the lungs. And that can obviously affect the oxygenation level of the lungs and the ability of the lungs to provide oxygen to the bloodstream. Very similar to what we saw during the COVID pandemic, where people had to be ventilated to support their oxygenation levels. So this is a similar scenario. If this occurs, we pick it up very quickly in terms of a drop in the oxygen level in the patient's blood. And because we monitor you in the high care unit post-operatively, we can generally pick that up very quickly. Because of that, or once we pick that up, we would need to support you with higher oxygenation levels, and that typically happens through something called nasal prongs, which is a specific way in which we deliver oxygen. Generally, for most patients, this is then a self-limiting condition which blows over the course of the next 48 hours or so. Fat embolism syndrome happens in approximately 4% of limb lengthening patients, but those 4% don't mean that every one of those patients would be in a life-threatening condition. In fact, the majority of them are clinically visible, so we pick them up, but they actually respond very quickly to treatment and they are transient. And only very occasionally does this become so severe that it actually becomes a serious problem that needs very specific attention. But rest assured, if you do your surgery in a system that is well structured and that has all the backups, this would be as safe as possible. The second condition, or the second complication that we discussed, was blood clots, for lack of a better term, or thromboembolism. And basically this is where a blood clot occurs in one of the lower limbs after big surgery, and that blood clot can come loose in the bloodstream and embolize to the lungs. So it can basically go and sit in the lungs and cut off the lungs' ability to oxygenate the blood. So very similar to fat embolism in some ways, but also very different in other ways. Now, we know with big surgery like hip and knee replacements, there is a risk of blood clots moving into the lungs. And because of that, we also worry about the risk in limb lengthening surgery. And most reputable surgeons would now have strategies to mitigate that risk. One of the common strategies is to use low molecular weight heparin injections for the first few days after surgery, and then combine that with oral blood thinning medication once the patient gets discharged from hospital. And we routinely provide that, and we routinely continue with that for a prolonged period of time after the surgery. And that is intended to reduce the risk of blood clots forming and circulating to the lungs.